Welcome everyone here at Duke and online for today's Think Global panel, Community Engaged Approaches to Global Suicide Prevention. It may seem like a little bit of a somber topic, but I think you'll come away inspired today by some of the amazing and truly life-saving work that our panelists are leading. My name is Brandon Canettle. I'm Associate Professor of Nursing and Global Health here at Duke and Associate Director of our Center for Global Mental Health. I'm really excited to welcome our outstanding panelists who are doing such impactful work in this space in settings around the world and here in North Carolina. A few logistics before we get started. Today's session will be recorded and posted publicly on the DGHI YouTube channel. And each panelist will give a brief presentation followed by a moderated discussion, and then we'll have time for Q&A after that. So we'll welcome questions from both our in-person and online audiences at that time. People in the room, feel free to just raise your hand when we get to the Q&A, and online participants can put questions into the Q&A tab at any time. We'll be monitoring those questions and we'll get to as many as we can during the Q&A portion. I'm delighted now to introduce today's panelists. I'll give some brief introductions, but please do take a closer look at their full biographies, which are on the event website. First, Marissa Maracini is an associate professor of school psychology in the School of Education at UNC Chapel Hill. She specializes in promoting student mental health and preventing youth suicide. Dr. Maracini has been leading research focused on developing and testing novel approaches to youth suicide prevention and prioritizing perspectives of individuals with lived experience throughout each phase of her research. Emma Mew is a psychiatric epidemiologist and postdoctoral associate here at DGHI in our Center for Global Mental Health. Her research focuses on the development and evaluation of community-based intervention to prevent adolescent suicide in resource-constrained environments, with experience partnering with communities in the Pacific Islands and East Africa. Ali Justo is with us online. She's a clinical psychologist and assistant professor at Florida International University's Department of Psychology, where she designs and evaluates scalable community-embedded family and caregiver mental health interventions with a focus on fathers to promote youth well-being. She was a clinical psychology student here, PhD student here at Duke, so it's always great to have her back. And finally, last but not least, Dr. Kim Madundo is a psychiatrist, lecturer, and head of the Department of Psychiatry and Mental Health at Kilimanjaro Christian Medical Center in Tanzania. He's one of only 4 psychiatrists currently practicing in northern Tanzania and has an interest in psychological trauma, depression, and suicide prevention, as well as developing interventions targeting these mental health challenges among young adults. So our first presenter today is Marissa.
Awesome, thanks. So I like to start, well, I'm so happy to get to kick this off. Thanks for having me. I'm coming all the way from UNC Chapel Hill, so I feel ways about being here, but I'm still happy to be here. And I like to start with a little self-portrait image in my slides because much of my work includes embedding creativity and art and kid perspectives. But that is actually a drawing that I did. It is not a child drawing, although people ask that frequently, which is fine. Head to the next slide. So I'm focused on suicide prevention in all of my work. I'm a school psychologist and I'm a licensed psychologist. And I'm really interested in how we can better translate clinical interventions across settings. And so just to kind of kick off the context here, we know that suicide remains a leading cause of death among young people worldwide and in the United States. And we've seen an increase in emergency department visits for suicide-related crises over the past decade and more. And this means that in addition to seeing this as increased help seeking, we're also potentially seeing an increase. The treatment that kids have access to in inpatient settings vary across hospital to hospital. There isn't a standardized treatment. At a minimum, most kids are getting medication management and discharge planning. There tends to be limited access to psychosocial interventions during inpatient care. And although there's an emphasis on discharge, oftentimes we don't pay much attention to where kids are actually headed next, including schools where most kids have numerous stressors that need to be addressed. So over the past 6 years, our team has developed and tested a virtual reality intervention that we deliver to kids while they're hospitalized for a suicide-related crisis. It's called Practice Experiences for Social and School Reintegration, or PRESSER. And the idea behind it is that kids will learn basic therapeutic skills in a VR headset, and then they'll practice using these skills in immersive, stressful, lifelike social experiences. And we hope that by both learning and practicing them while they're still in the hospital, they're more likely to use them in real life, more likely to use them in schools, have an improved recovery, and then potentially an improved reintegration. But although we built this based on the constraints of the hospital setting and based on youth voices over the years, we've seen a lot of barriers to implementation that we're trying to address now. So next slide. We have, over the last 3 years, really focused on partnering with teens with lived experience to expand our intervention and better meet the needs of some of our kids who are most at risk for suicide and some of our kids who've been overlooked in our research. So specifically, we've partnered with teens who are hospitalized who identify as ethnic or racial minoritized and or LGBTQ+, because we've seen both an increase or a steady high risk in both of these groups. We've also seen that these kids tend to be overlooked and their voices tend not to be heard. And in general, not just this subpopulation, but kids with suicide-related risk oftentimes are left out of decision-making when it comes to their interventions. So it's been a wild journey. We spent a lot of time building safety protocols and testing them and refining them with kids so that we could safely work with young people who have recent intense suicide-related crises together in a group. And it's a scary thing to do. And so I want to talk about some of our challenges. There were so many challenges that we faced. I think the largest one that I want to center today in this very brief talk is how tricky it is to both center lived experience without overloading kids and asking them to do too much. This is a tricky balance that we have to talk about in every aspect of our work. And when we're partnering with young people who have mental health difficulties, it's particularly important. We both want to empower them to have a voice, but we also don't want to depend on them for any of the work that needs to get made. So a big takeaway of this work is really mainly that we can safely do this. Our team has developed a protocol, we've used it, we've gotten feedback from teams with lived experience, and we were able to safely partner with teams and co-create more scenarios for our intervention. Did it go perfectly? Did we make a lot of mistakes? Yes and no to both of those, I would say. And we have protocols that folks can use who are interested in doing these kinds of things. Okay, so where we're headed next is where I'll leave you. We have a ton of work to do more generally on sort of refining the intervention. We need money to make it better, make it less robotic, et cetera. We get lots of input from teams about what we need to do. So that's one aim. But the other is really more work in this area, more creative, collaborative work that's focused on some of our more vulnerable individuals in the world. We can do this work together. And so if you look at the image all the way to the left, I'll just end with that one. That is a graphic novel that was co-created by a father and daughter, Ethan and Naomi Sachs, with lived experience around the teen being hospitalized for a suicide-related crisis. It talks about her experience of returning to school in an apocalyptic setting that's incredibly engaging for kids to learn from. So I think we need more work like this, where we're not just creating these packaged evidence-based interventions, but we're also creating learning opportunities based on kids' experience for kids to enhance their entire experience and contribute to suicide prevention. Thanks.
I'm up next. Hi, everyone. Good afternoon. Today, I'll be sharing some of the work that I've done in the Pacific Islands, specifically in American Samoa, looking at suicide prevention work among adolescents. Next slide. So for those who aren't aware where American Samoa is, it's an unincorporated United States territory located in the South Pacific. And so when we started this work about 6 years ago, there was sadly a cluster of suicide deaths in the territory that led local public health officials to declare a youth suicide crisis. Next slide. And specifically, this crisis is among adolescents. And so one actually estimate found that about 1 in every 3 high school students in the territory had attempted suicide in the last year, which is incredibly high and concerning. And even though many adolescents on island are thriving and are doing well, there really was and continues to be a community identified need to implement and create suicide prevention efforts for adolescents in this context. Next slide. So American Samoa is an Indigenous context, and as our team was cross-cultural in nature, we had folks from Samoa. We also had folks who weren't Samoan, like myself. So from the very beginning of this project, we were very intentional about integrating decolonizing methodologies into this work. And so what that really means, in essence, is we took the sentiment from this quote, "Nothing about us without us," and we really tried to interweave that into the very framework and fabric of this project from beginning to end. So next slide. So following the spirit of the project, first and foremost, we went to youth and we asked them, you know, what can we do to actually prevent suicide in this context? And what knowledge do we need to be able to do this? And so guided by our youth and our advisory board, they actually guided us and recommended that we move into developing a family skills intervention so that it can kind of train both parents and, children and caregivers skills and tools to be able to be more resilient in the face of life stressors. Next slide. And so with that, following the direction of youth, we then did qualitative work with both community stakeholders and adolescents to develop a framework to build this intervention, this family skills intervention. And so together we co-created this model, which is a whanau or a house model in Samoan, which basically shows all of the different intervention components that we would need that are kind of aligned with Samoan values, but also build upon local strengths as well. And so now, fast forward the past couple of years, actually, not to Brandon, fast forward. Fast forward a couple of years. We are now actually trying to turn this model into something tangible and concrete that can be not only implemented, but scalable. And so now we are cross-culturally adapting the Strengthening Families program in American Samoa. Now, next slide. So even though this project has largely been very successful, that doesn't mean that we haven't hit road bumps along the way. And of course, I know as Marissa said, there's so many challenges to this work. For me, my experience, the biggest challenge we had was really finding enough time and resources to adequately not only build trust, but protect trust. Because as you can imagine, this is such a sensitive topic because you have not only suicide prevention in a context where it is so stigmatized, but you have suicide prevention among kids and among Indigenous kids. And then adding to that, you also have parenting practices where if we're not careful to kind of frame things delicately and with the community, it could be perceived as being critical towards parenting. And that's not our intention, but it's just so delicate and so sensitive. I would even argue, in order to do this work at all, it really requires so much trust with the community. And so to kind of overcome this, our team has gotten very creative at finding solutions and being very resourceful in finding kind of time and ways to build this trust. Next slide. And so next is our team has submitted an R01 to hopefully evaluate this intervention that we're adapting to see if it's impactful for suicide outcomes, which is exciting. And next slide. So what I really hope that you'll get away from this talk is that listening to community voices and not just listening, but really authentically trying to respond to community needs in this kind of listening process really pays off. And it pays off not just in terms of innovation. We've developed this intervention framework that is really innovative and new, but also in terms of impact, because we have partnered with policymakers and community leaders since day one and clinicians since day one. So now that we have actual results to share, we have this kind of embedded policy and clinical pipeline to translate our research into impact. And so just on one last note, next slide. I just want to thank the many, many partners and collaborators that have contributed to this work in American Samoa, because they not only have donated their time, but oftentimes even resources in kind to make this project happen. So thank you.
Okay, Allie, you're up. You're muted.
There I am. I was gonna do the whole talk muted. Do you think that'd be a problem? Hi everyone. It's good to sort of be back. I wish I could be there in person. I feel like I get more nervous on Zoom because I can't, my clinical psychologist, I want to feel the vibes of the room and how everyone's doing. But I hope everyone's doing well. I'm excited to talk about clinical applications of suicide prevention in Kenya. Brandon, do I have to do that next thing to you? Next. Thank you. Perfect. I'm going to be talking a lot about work that has been done in collaboration with Moi Teaching and Referral Hospital in Eldoret, Kenya, and in partnership with AMPATH, the academic model providing access to healthcare, which is a research consortium of North American schools, the Kenyan Ministry of Health, and Moi Teaching and Referral Hospital. Next, and that's Eldoret from the plane. I'm going to talk about suicide prevention really in the context of clinical research and clinical research projects that have been ongoing since my time as a graduate student at Duke and beyond, now in Florida. In Miami, I'm hoping Durham is not too cold. It's nice and hot here. So sending you all some warmth in case it's cold. But really, this has been in the context of a family therapy treatment for family conflict and adolescent distress that has been delivered in family homes in Eldoret, and then also working with fathers experiencing depression and alcohol use that's been delivered by peer fathers in Eldoret. Next slide. And across and within this research, as you might imagine, with the topics that we're dealing with, and in doing any kind of mental health work, clinically or otherwise, assessing and addressing suicidality in the context, particularly of community-embedded trials, so outside of a hospital system, in a context with limited resources. And at the time when we were doing some of this, no real adapted kind of evidence-based supports for dealing with suicidality. How do we deal with disclosure experiences and intervention with suicide among our participants and across our team? Next. So really out of a clinical need, clinical experience, what we knew existed in the literature already and what seemed to be feasible and fit with the interventions that we were implementing in these contexts, we, as part of these research projects and studies, chose the safety planning intervention, which is a 6-step collaborative planning process, starting with understanding triggers around suicidality, internal coping, and so on. Next slide. A key piece of this treatment is in step 6. If we were working with teens that Marissa was working with, would be to say, hey, you're experiencing suicidality. What happens the next time you're experiencing this? Let's call 911. What resources in your community? What's the nearest hospital? Where are you going to go? So that's kind of a key step of the safety planning process that we weren't really had a equivalent parallel for in Kenya. There was no really one equipped, no 911 to call at the time. And similarly now still nowhere to call. So one of the key cultural and contextual considerations that we made were how to build out that step to really think about key leaders and people within the community itself that an individual would feel comfortable reaching out to, and including going through a plan, problem-solving barriers of how they wouldn't reach out in a moment of crisis, along with other cultural considerations for the other steps as well. Next slide. I think obviously, and I've heard across a lot of talks, our biggest challenge was a lack of resources. Where are we going to send people, and who are we going to connect them to when maybe our existing treatments within the context of this research is not enough. Next slide. But one of our key takeaways we've seen across this work and all of our work is the importance of training everybody and constantly training and talking about suicide. How are we assessing? How do we do safety planning? So everyone from the team clinician to the surveyor is getting trained in assessment and safety planning. And it's something we're constantly talking about and making sure teams feel supported and equipped to address it the best they can. Next slide. Where we're going next, this was my attempt at like a networking slide, but we'll update my picture soon with some I want a team to draw me a picture, Marissa, of a better network than this, but is hopefully connecting with some of the people in this panel and some of the people in this crowd and thinking about how do we expand training and capacity building around suicidality and potentially leveraging digital tools and solutions, even AI-driven solutions to address this gap, even in terms of national suicide hotlines and places to go in crisis. Next slide. That's all. Thank you.
Yeah, Kim, thanks.
Hi, everyone. I'm joining from Tanzania, and it's just after 8 p.m. So it feels a bit odd joining a meeting and a presentation, but I'm still happy to be here. I'm going to be talking about the Ideas for Hope intervention. So this was a telehealth-based counseling intervention to reduce depression and prevent suicide and improve HIV care engagement among adults living with HIV. Next slide, please. And so just to briefly talk about the situation in Tanzania, the psychiatrist to population ratio, there's about one psychiatrist per million people, which is significantly lower than what the WHO recommends. And there's even fewer clinical psychologists for the entire country. Tanzania also has the fifth highest prevalence of HIV worldwide and the fifth highest incident rate of HIV. Mental health services are generally not integrated into HIV care, and also where mental health services are available in the country, this is mostly zonal level or national level facilities, and so there's only 5 or 6 of these for the whole country. Next slide, please. So considering all of these challenges, we sought to develop an intervention that would not only address these challenges, because people living with HIV still face stigma, and the stigma contributes a lot to common mental health challenges like depression and suicide. And you may know that depression among people living with HIV, there's up to 3 times higher risk. And with suicidal ideation and behavior, there's up to 100 times risk. And so to explain the model or the framework for this intervention, we'll use the model of a house similar to Emma. And so the foundation upon which you build the house, this is someone's personal values and their reasons for living. And the 4 pillars of the house, which is the main supporting structure for the house. These are living healthy with HIV, living free of stigma, being emotionally healthy, and being able to fulfill your basic needs. And the roof that, provides shelter is someone's sense of safety and hope for the future. These are components that were identified from interviews with patients, so people living with HIV, but also with healthcare workers. Next slide. And so throughout the intervention development process and the pilot testing, we had to adapt certain pieces. And so not only translating and validating tools that had never been used in the country before, but also abbreviating the Columbia Suicide Symptom Rating Scale, which is much longer in its full form, but we chose one item to be on a screener prior to recruitment of participants onto the trial. And just the process of selecting that one item and how to ask it. And the screening was conducted by HIV care nurses, so staff who are already part of the HIV care service system. We also wanted to measure levels of distress, and one of the most commonly ways to do this is asking someone on a scale from 1 to 10, how are you feeling? But this is an approach that does not translate well in Tanzania and in Swahili, and we found that a visual aid, so something like a distress thermometer, can be a lot more helpful in people being able to conceptualize levels of distress. And then the task shifting model was crucial for this setting, considering the lack of human resources and lack of mental health specialists. And so we utilized nurses from the screening process and in recruitment, but also nursing counselors to deliver the intervention. And these were quite junior diploma level nurses who conducted the process with very high levels of quality and fidelity to the intervention. Next slide. So just like what Marissa said, there were quite a few challenges considering the setting and the stigma around HIV and with mental health. But the ones that I wanted to highlight today were integrating targeted mental health screening, particularly for suicidal ideation, a topic that is highly discriminated against. Suicidal behavior is actually criminalized in Tanzania, and many healthcare workers are not comfortable discussing suicide and depression, but also would not ask those questions because what am I supposed to do if I detect this and I don't feel like I have the knowledge or skills to address this? But also transferring those skills, those procedural skills of screening and counseling, intervention, delivery in a place where that doesn't really exist. Next slide. And so considering those challenges, the one thing that I want you to take away is that it is possible to build something that is really impactful in a setting that has such critical limitations and where things may feel like they're too difficult to implement. Using an approach that is based on what exists and that can still be really impactful and can make mental health care really accessible. Next slide. And so our next steps are also an R01 grant to test the effectiveness of ideas for hope and explore the mechanisms of change. But also the original pilot testing was conducted at 2 sites, which are both rural, urban located sites. And for the R01, we'll have a combination of 14 sites that are both urban and rural. And another exciting direction is an R34, where we'll be adapting the ideas for hope intervention for an emergency or acute care setting. Thank you.
Fantastic. Thank you all so much. And they all stuck to the time, which never happens. So we have a good amount of time here for some moderated discussion and then for open Q&A after. So for those of you online, feel free to put those questions in the chat. And for those in the room, give some thought to what you want to ask this outstanding panel around their amazing presentations. So let's start with Emma. Emma, you did some great conversation about the process of building trust in your community, and suicide is such a personal topic, and lived experience, whether one's own or loved one's experience, can be really hard to talk about. How do you harness the power of people's stories without feeling like we're using those stories to advance an agenda?
Yeah, thank you so much. And this is a question that I've thought a lot about too over the past 5 years doing this work. I think first, before answering the question, kind of backing up a bit, I think first, I think it's important to think about whose agenda are we advancing, and first and foremost, and having that involved from the very beginning. And I think even too, thinking critically about who is this, who will benefit from this research project, and having all of that in mind as we create this agenda. And I think too, kind of answering your question, I think having communities actually drive the research agenda is a way to have kind of the most ethical engagement in my, or at least maybe gold standard for ethical engagement. And so for me, from my experience, at least with this project, as an outsider on this team, I found that my role was almost more being an observer and having the community really driving this research forward, and having the community drive and bring the energy to and momentum to bring this research forward. And so I feel like, and now answering your question about almost that kind of interpersonal dynamic between researcher and participant, and having a participant share very vulnerable stories and experience in pursuit of this research goal, I find in the kind of container of this culture that we set, where the power dynamics are shifted, I find that almost the participants are coming and approaching us and actually giving us their stories as almost a gift, rather than another kind of energy flow, so to speak. So I feel like for me, having this kind of model would be kind of a gold standard for us to kind of strive for in this space.
Sure, that's a really great response. And I know in our work, as we moved towards intervention and tried to kind of move towards intervention maybe more quickly than some other teams had, that was really appreciated, I think, in our approach of knowing that we weren't just going to ask the questions, that we were really trying to co-develop solutions, and moving in that direction created a lot of investment too. So, all right. Kim, you are gaining expertise in transdiagnostic approaches to mental health support. Can you tell us a little more about that approach to suicide prevention and how it emerged in collaboration with community members in Tanzania?
Yeah, so suicidality as it currently exists in the DSM, it's one diagnostic criterion for major depressive disorder. And we know that suicidal thoughts, suicidal behavior can occur even when someone is not severely depressed, even when there is no formal psychiatric diagnosis, but it can also frequently co-occur alongside many other mental health challenges like substance use and psychosis and anxiety and panic attacks. And so transdiagnostic approaches seek to identify things that connect all of these multiple challenges, whether it's sociodemographic factors or whether it's the symptoms that overlap between multiple mental health challenges. And in a setting like Tanzania, where human resources are critically limited, mental health services are highly inaccessible, it makes sense to develop or adapt interventions that can identify these common factors that can address multiple challenges simultaneously. And how this came to be, or from collaborating with community, is from the interviews that we did as some of the formative work for Ideas for Hope, in understanding that it's not always someone's HIV diagnosis that is a trauma. Sometimes it's the other things like living with food insecurity, and there's family conflict, and there's job insecurity, and there's poverty, things that many people are living with. And perhaps these are the things that we should be addressing rather than just focusing on someone's depressive symptoms or someone's suicidality, but addressing what underlies all of that. And these things are not only contributing to depression and suicidality, they may also be increasing someone's risk of other comorbid mental health challenges.
Yeah, I completely agree with all of that. And I think that the shift towards talking about distress was one of the biggest ones for us in Ideas for Hope, that it went away from us labeling somebody or diagnosing somebody with a condition, which often felt very stigmatizing and kind of somebody else telling them what they were experiencing, to them describing their own distress, their own challenges that they were facing that might be driving their hopelessness or suicidal thinking, and allowing them to define their own conflict and their own challenge and their own distress really was a shift away from kind of the clinician as the one, or the interventionist as the one who held the power, to the person being able to define their own experience. And I think it was really valuable. All right. Marissa, I know a lot of our international partners in low resource settings are eager to explore new technologies like your VR intervention. But how do we find balance between providing the latest technologies while keeping in mind the resource limitations we're facing and offering those types of interventions in the places where we're working in other parts of the world?
Yeah, it's a great question. I think like some of what everyone has already talked about is pretty salient here, because it's less about the technology and more about how you can make something accessible. And so in the context that I'm working, VR is actually a great tool because we don't have enough trained staff to deliver this kind of intervention. It's a contained headset, one-on-one with an expectation. It works well. It's not really necessary for a lot of skill learning or interventions. And so when we think about like using technology intelligently, it's a combination of thinking about what's necessary for teaching or learning, and also what's feasible, and also what are people already using. And so I would encourage folks to think about those three different buckets as they navigate what to do. And I think like it would feel silly not to mention generative AI and this like tremendous impact it's having on everything, and our fears. I think a lot of us have a lot of fears around the lack of humanization that can stem from this. And so I think it's really critical that if those of us who are doing this work kind of step out in front and think about ethical ways of using things that are accessible to the general public, because people are using them. And so I feel the same way about social media as I do about virtual reality, as I do about AI, that if people are going to be using these things, we need to be savvy to how they should be used and make sure that we're providing input throughout all of this. So I know that's not exactly what you asked, but I think I can't step like 3 feet without someone saying something about AI or interfacing with something that's AI generated. And I think we have to be talking.
All right. And Ali, suicide is still illegal in some of the places where we work, including in Tanzania, and it was recently decriminalized in Kenya. How have you navigated some of those challenges ethically?
Question. Part of me wants to be like, how have you done it in Tanzania? And I also, Kim just wanted to comment too, and Brandon, on the emotional distress piece, that we should talk more, because I think we've been seeing that a lot, particularly with the men that we've been working with in the context of fathers, and seeing how to report symptomology and depressive symptoms, and suicidality. So I think that's super relevant across a lot of our work. To your question, I think we've been, in some ways, my experience of it as this one person doing work in this one context with these few teams has been, we're almost in the bubble of our research projects where we haven't confronted it in a way I would imagine maybe some of my colleagues or other individuals may be experiencing it, and the level of stigma and how it's playing out. And what I mean by that is we weren't doing a research study on suicidality. It was something we were assessing in the context of these trials and would come up. So we weren't bumping up in any like policy or hospital or community system level against it, any pushback at any point. And then when families were usually pretty free with talking about it, the caveat being we never then went in and explored, how many people we might have missed, or how many people didn't feel comfortable, or what that level of stigma and how it might have played out. I will say, since it's been decriminalized, I think you heard me alluding to, they're doing a lot of work, I think, at the national policy level to do more research, put things in place, get a better understanding of sort of the numbers in the country, and also they don't have a national suicide hotline, but they're trying to do something similar, but it's not quite functioning yet. And so I think I think it's creating more space and room for like capacity building in this area at the national level.
Thank you. Yeah, Kim, a quick follow-up, and maybe Kim, you can start with this one, which is Ali mentioned that there is no 911, right? And here in the United States, as clinicians, we're ethically obligated to connect people with inpatient treatment or a higher level of care if we're concerned about their safety or well-being after an outpatient session, for example. In Tanzania, those resources often aren't available. And the inpatient care that we do have, we pretty quickly learned in our work that it was not a healthy environment for people with milder concerns, even if it was something that would historically or would, like in other settings, be lead to hospitalization, because the inpatient unit was primarily people with very severe psychosis. And so somebody who is experiencing suicidal thinking wouldn't have a good experience there, or a healthy experience there. Can you maybe speak to how we've tried to navigate some of those challenges and how you wrestle with this need for a higher level of care, but also being concerned about what's available for people?
Sure, yeah. It's interesting because in a country where suicidal behavior is illegal, it's considered a crime. And just to clarify that persecution, it does not happen often, but it does happen. And as as people are gaining more awareness about mental health, and there's certainly some sensationalism around mental health crises, whenever there is a suicide attempt, whenever there is a death by suicide, and that becomes publicized very quickly and often in quite harmful ways, and that can have a ripple effect in the community where people do get arrested and people um, are persecuted, basically. But within the Ideas for Hope project, which was hospital-based, um, one of the most important and positive things was that healthcare workers assured us as researchers that they would maintain confidentiality, that that was part of their practice. Um, and that if patients ever reported this, it was never on their minds to report it to the police or to contact the legal system, even though that is technically what should be happening. And also that, yeah, similar to Kenya, we don't have suicide hotlines. You can't really have a suicide hotline in a place where it's considered illegal, because that would basically be, reporting yourself to the authorities. Um, so yeah, it's a tricky balance of us reassuring, and we published a paper on this, what patients and what HIV care providers thought, two papers, what patients and HIV care providers thought about the fact that suicide is criminalized in Tanzania. And it was almost unanimous that people felt this was antiquated, it was unnecessary, it was harmful, it was a barrier to care. And I mean, I'm really happy that we asked those questions, that we got those answers, and that we see within the healthcare system that there is definitely a push for change.
All right, now opening it up. Questions in the audience or online?
On Kim's last comment about a push for change, I'm thinking about another thing that he said as well, regarding certain skills or certain knowledge among the folks that are on the team being virtually non-existent and having to do that training as part of the research study, where maybe if you were implementing it in a different setting, it would have been kind of part of basic nursing training or something else. And also, I think maybe it was Allie that said, or maybe it was somebody else, about training the whole team kind of and it makes me think of the same thing, because some of the work that we've done, we've found, there is this gap of knowledge or skills or processes in many cases in the setting that we're working, and we kind of have to step back and take a bigger look. Okay, maybe we need to work on this system level change or training or whatever it might be. I wonder if any of you can speak a little more on those kinds of challenges and any lessons learned of how you approach, and this is especially has its layers of complexity as an outsider that's working in a different system of, okay, how do we implement and partner to make these changes or improvements? How do we do that? What's worked, or what have we learned didn't work?
Yeah, I'll start with that. Every member of the team, and that is so crucial. And in our work, we've taken a lot from business, and some of it is around user engagement, user-centered design, and businesses get a lot of money to do this well. And so we've borrowed some of those lessons in healthcare. And one of them is about the culture of a place is what everybody you encounter in that place, from the person who cleans the place to the highest level administrators. And so that's something we've really started to pay attention to as well, is that everybody needs to have some fluency in mental health. Everybody needs to be thinking about recognizing people who are in distress and connecting them to resources. And it's something we've really tried to integrate, but love to hear from others on the panel about this too.
The only thing I'd add to what you said to the culture piece, Brandon, is it's not quite getting at the bigger question, but is the culture of help seeking and support, never feel afraid to ask a question or ask for help or supervision, and listening to that, trying to listen to that uneasy feeling, whatever it is, or even if you're unsure, the culture of reaching out has been a key tenet of some of that stuff too that we've tried with the suicidality specifically.
Yeah, I would also say for many of the participants, so people living with HIV, but also living with serious mental health challenges, you're enrolled in a clinical trial, but this is the first time that you had the opportunity to talk about your mental health. But for the nurses as well, and for the healthcare workers that we interviewed, this was actually one of the moments that I truly came to appreciate qualitative research. The in-depth interviews also allowed some of the healthcare workers to discuss what they were experiencing, witnessing their participants being lost to follow-up, disengaging from care, knowing that part of it was probably due to their mental health, and not really knowing what to do or feeling like they were doing the wrong thing. And so the interviews allowed a space to have a conversation about what they were doing, what they were worried about. And that really gave us the information to, to inform the intervention and how to task shift. And yeah.
And just adding one more piece too, in our work, and I think just building off of what everyone else is sharing about setting this kind of culture of safety, we were very intentional to create a culture of trust and safety. And we had a lot of local clinicians come and even speak to participants at the focus group before we started, as kind of a way of building trust and setting trust so that youth would feel comfortable coming forward.
Questions? We do have one in the chat. This is from Lakeisha. It's for the folks on the panel who are working, I guess, more with adolescents. She's asking about teens and suicide prevention, and what are some of the ways that schools can implement policies or procedures to bring about a positive change in mental health. The question specifically mentions like stuff like school uniforms, or social media regulations, phone regulations, things like that.
I'll take that as the school psychologist. Those are great questions. So what we know from, decades of suicide prevention research in schools, is that universal suicide prevention programs can make a difference and they can be effective. And also school climate matters really more generally. So it's a combination, and oftentimes, so there's two comprehensive school-based suicide prevention programs that have shown reduction in suicide attempts. Those are Signs of Suicide and YAM. And then there's also recent study that came out that Sources of Strength, another kind of universal social emotional learning program, has actually prevented deaths in large scale trials. And all of them, they're all distinct. Signs of Suicide is more psychoeducation oriented, but YAM and Sources of Strength are more interactive and role play oriented. But they all have an imprint on the school climate more generally and what mental health means. The question specifically though about policies for phone use, uniforms, all these things, the effects of these policies are largely unknown, like restricting access to phones in and out of schools. I think there's some basic intuition that folks are using around. We do know that access to smartphone technology has at least contributed to some extent to some problems for certain kids, right? Like, I'm a classic researcher here. I'm not going to say that, like, put it all on anything in particular. So certainly having guidance around phone use is important, but to my knowledge, there aren't large scale studies that have looked at schools that prohibit phone use versus schools that don't. And there's a large group of folks who are really advocates of meeting kids where they're at. And so we can't always just depend on policies, although they're incredibly important. But if kids aren't allowed to access their phones in schools, they're going to access them somewhere else. So we can't just do that alone. It can't just be a restriction. It also has to be a full kind of understanding of what kids are using it for and teaching them how to safely engage in these kinds of things.
Sure.
Oh, no, go ahead.
Thank you. I believe it's for Emma. I was really interested and concerned about the numbers and the profile of suicidality you spoke about in American Samoa. I was wondering if there's any kind of work on the root of this. Is it biological, cultural, or an outstanding surveillance system that allows us to see such impressive numbers?
Yeah, great question. I think the take-home answer is there really isn't a lot of research. The bulk of research that has been done by my team, and it really is burgeoning. So we've really done mostly qualitative and a little bit of quantitative, but we're really not even really digging into identifying real concrete risk and protective factors. And your point about surveillance system, it also doesn't really exist. There is, of course, I think surveillance system in terms of like suicide deaths, but in terms of suicidal thoughts and behaviors for kids in American Samoa, it really just doesn't exist. And even that estimate of 30% came from a locally run survey from a local NGO that of course has biases and things, but anecdotally from the work that I've done, 30% seems pretty spot on. So to answer your question, there's so much more work to be done and we're not sure, but I think a mixture of all of the things you said is probably right.
And my question was also for you. So we heard about some of the suicide stigma in Tanzania. So I wonder what your perception is of the stigma in American Samoa. And then in your talking with youth and community members, like to what extent were they interested in or willing to talk about decreasing distress versus like enhancing the protective factors and talking about community strengths?
It's a great question. So your first point about the stigma piece. So certainly there was stigma among youth. And again, this is kind of like the first time anyone's ever really looked at suicide prevention in a Pacific Island context in this kind of way. So we're all kind of learning as we go. But my sense is the stigma is quite high for many different reasons, but I think cultural reasons, especially in the Pacific Islands, there's kind of this, as participants have said, warrior mentality, where especially among boys, it's kind of almost like taboo to share your feelings or to show weakness, almost needing to show strength. And I think that really feeds into it and feeds into a lot of the kind of suicidal behaviors. And your second question about leaning into kind of reducing distress versus enhancing protective factors. I think probably more in terms of enhancing protective factors seems to be what folks are biting into a little bit more, and that aligns really well with the kind of asset-based approach that our work is doing. So I think we're also trying to lean that way as well, but it seems like there's kind of appetite for that direction. Thank you.
I have one last question I'll put out to the whole panel. So we're really grateful to have this panel of experts in suicide prevention. And I know I've encountered colleagues, even really seasoned mental health professionals who are hesitant to address suicide in their work due to concern about the perceived risk of the work, feeling like they aren't experts in the area. What advice might you have to some of the folks in the room or people doing mental health related work who haven't yet addressed suicide prevention in their work?
Let's go in order. I'll go first. Ooh, so much. I would say like partner up. It is pretty intense work and there's people out there doing it. So don't be afraid to start it, but do it with someone else who also has a little bit of experience so that you're not alone. I think it can be incredibly lonely to do this work and scary. And so when I'm engaged in thinking about risk and follow-ups, like I want to make sure my team and I are all on the same page and having larger conversations about this work. But it's really important, and I will say that people who are struggling with these thoughts are going to be struggling with them whether or not you ask. And so if you don't ask, it's a missed opportunity to provide support. And that alone, I think, can kind of get rid of some of the fear because you're not going to cause any suicidal thoughts or behaviors if you're directly asking about it, but you are going to maybe help uncover something that someone hasn't felt safe to share before.
I can go next. I think first I just want to kind of acknowledge that feeling is valid in the sense of, I mean, the work we do is really hard and it is really involved and it requires a lot of careful safety planning. And I think even too, for a researcher, at least in my experience, it's heavy stuff. I mean, we have a lot of responsibility for our participants, but also we hear a lot of really, really heavy stories on a pretty frequent basis. So I think just to say that I think the concern is valid, but I think from my own personal experience, the challenge is very much worth it, seeing the impact that we have. And I'm thinking, and I'm sure everyone in this panel can speak to this too, I've had so many not participants, but community members and stakeholders come up to me and thank me for this work and say how impactful it is and how it is actually saving lives. And I think that's kind of overrides any of the challenges at play, just showing how rewarding it is and how we are collectively saving lives in this work.
I completely agree. And I think the two things that we would get when we're going to HIV clinics, for example, where first of all, I don't have time. Have you seen the waiting room? Look how busy it is. I don't have time to provide 20 minutes or half an hour to counseling for each of these folks. But the second thing was often this emotional piece of, I'm not trained in that. It sounds really hard. It sounds really emotionally taxing. I'm not sure if I'm the right person for this. And I think that second one is often, the first one we kind of work through some of these task shifting and resource kind of solutions. But the second one, I think often they have to get in there and actually see the benefit that they're providing and realize that, yes, it is heavy work, but it's also incredibly rewarding when you see that you are having a positive impact on people's lives. So it's often my answer for people who say it sounds really hard is it's also very rewarding. Kim or Allie? Oh, did we lose Al? Okay.
Yeah, I that question makes me reflect on my medical training, and I noticed some parallels between training as a doctor and this question about researchers' hesitancy, in that similar to what Marissa said, the myth around discussing suicide, asking questions about suicide might precipitate someone to attempt or self-harm. And also the fact that, so my answer to that would be, again, to partner up, but clinical supervision that is part of clinical practice that can be so helpful for anyone, regardless of your level of experience. But it's just really important to have someone to speak to about the things that you're hesitating on or concerned about. And on the Ideas for Hope project, we had quite junior nurses with minimal mental health training, and the clinical supervision allowed them to express their concerns, their hesitancies, and it kind of puts you, the supervisor, the researcher, in a position where you have to prepare and you have to figure out what is the right thing to do in this situation. And so I guess the answer to that would also be to partner up and to speak to other people. But I just find it interesting that the research methodology can incorporate pieces that are also very clinical in a way.
Great. Well, thank you all so much for joining. Thank you to our panelists for sharing your wisdom, for sharing the wonderful work that you're doing. And thanks everybody in person and online for joining us today. Finally, a quick reminder that we'll have this was recorded and we'll have it posted on the YouTube channel by the end of the week. So feel free to share that recording with others in your team who you think might benefit from this. And yeah, thank you to DGHI for hosting us today and to all of you. Thank you.
We have a 10 minute. Yeah, that's okay. A little lunch. Yeah, I have to be there.